afternoon. Very warm welcome to Mountains Beyond Mountains, the life and legacy of Dr. Paul Farmer, sponsored by the Duke Global Health Institute and New Student and Family Programs. My name is Gavin Yamey. I am a professor of global health in DGHI, the Duke Global Health Institute, and of public policy over in the Sanford School. And I direct a center here at Duke called the Center for Policy Impact in Global Health. We are a policy lab that tackles some of the big picture strategic questions in the delivery, organization, and financing of global health. It really is my great privilege and honor to be moderating today's panel, in which we are going to reflect on the extraordinary life and contributions of Dr. Paul Farmer, physician, anthropologist, writer, activist, humanitarian, and of course, one of the world's most beloved Blue Devils. He was an undergraduate here. He attended as a Benjamin N. Duke Scholar, graduated with a BA in medical anthropology in 1982. And Paul stayed very deeply connected with the university throughout his life, including serving on the board of directors of our institute, DGHI, as a trustee emeritus and as Duke's commencement speaker in 2015. In fact, Duke's most prestigious global health event of the year is the annual Victor Jade Distinguished Lecture. And this year, on January the 26th, the event was a conversation that I moderated between Paul and his colleague, Dr. Agnes Binagwaho. Many of you know her as Rwanda's former Minister of Health, and she's the Vice Chancellor and co-founder of the University of Global Health Equity in Kigali, Rwanda, university that Paul also supported. In fact, there's a Paul Farmer Scholarship Fund. It's the first university in sub-Saharan Africa to offer a master's in global health. In Paul's book, Pathologies of Power, he wrote, "What happens to poor people is never divorced from the actions of the powerful. And to redress global health inequities and to empower the disempowered, Paul co-founded Partners in Health, PIH, an NGO that provides free healthcare, both in low-income countries like Peru, Rwanda, Haiti, but also here in the US in low-income communities." And many of you have watched Bending the Arc, the 2017 documentary. And if you haven't, please come by 7 o'clock tonight at the Griffin Film Theatre, an extraordinarily compelling documentary. I was personally very fortunate to know Paul as a friend and colleague. We worked on a number of projects together on health and human rights and on global surgery. And however busy he was, and wow, was he really very busy. When he was with you, he was always really present. It was very striking. And he always seemed to kind of lift you up. You might have not have felt like you were contributing much, but he always found a way to make you feel like you were playing a critical role in the struggle for global social justice. And today we have 4 very remarkable panelists who are going to share their own reflections and experiences knowing Paul and working with Paul. And let me briefly introduce them. Their long and very impressive bios are in the Family Weekend brochure. There has been one change to the original lineup, which I'll mention in a minute. So joining us from London is Chris Beyrer, the new director of the Duke Global Health Institute. Welcome, Chris. Chris is an internationally recognized physician epidemiologist who has worked on the front lines of HIV/AIDS and COVID treatment and research. He's a senior scientific liaison to the COVID-19 Vaccine Prevention Network and past president of the International AIDS Society. And he has served as an advisor to so many organizations, too many to name here. I'll just name a couple: PEPFAR, the US President's Emergency Plan for AIDS Relief, and the HIV Vaccine Trials Network. Before joining us here at Duke, he was the inaugural Desmond M. Tutu Professor of Public Health and Human Rights at the Johns Hopkins Bloomberg School of Public Health. Joining us, I think, from Chicago. Are you in Chicago, Adia? Yes, Chicago representing Dr. Adia Benton, an associate professor of anthropology and African studies at Northwestern University, where she's affiliated with the Science in Human Culture program. Dr. Benton is the author of the award-winning book, which I ask all my own global health students to read. It's called HIV Exceptionalism, Development Through Disease in Sierra Leone, and she's currently writing a book about the West African Ebola outbreak. Her other writing has touched on the production of anthropological knowledge in infectious disease outbreak response, racial hierarchies in humanitarianism and development, the politics of statistical reasoning in epidemics, and gender and racial capital in professional sports. So unfortunately, Dr. Bailor, Executive Director of PIH Sierra Leone, had a last-minute commitment yesterday, but I am very delighted that joining us from Sierra Leone is his PIH colleague, Jonathan Lasher. Jonathan's been with PIH since 2009, spent many years managing programs and operations in Haiti, including the response effort to the 2010 earthquake and the cholera outbreak. And in 2014, he helped found PIH in Sierra Leone. During that outbreak in West Africa, he was PIH Sierra Leone's Chief Operating Officer from 2014 to 2016 and Executive Director from 2017 to 2021. And there is, in fact, a Chicago, I know I don't pronounce it properly, a Chicago connection in that Jonathan has served as a mentor to students from President Obama's Scholar Program at the University of Chicago. And lastly, with us in the room, IRL, as they say, is Jade Cho, Duke class of 2019, yay. Jade is a medical student now at UC Davis School of Medicine, where she's part of an honors research pathway and co-director of a student-run clinic for low-income and uninsured Asian immigrants. When she was an undergraduate here at Duke, she began a community-based nutrition program project in Argentina. She conducted research on mosquito-borne diseases in Costa Rica and researched delivery models for anticoagulants in sub-Saharan Africa. Jade spent 6 years organizing with PIH Engage, which is the grassroots advocacy arm of PIH, and served on its national steering committee from 2018 to 2021. So welcome one, welcome all. So Adia, I want to begin with you. As we reflect on Paul's life, I would love you to help us get a measure of the man. You wrote a very beautiful piece, which I recommend to everybody. You could Google it. It's called Curing the World by Changing It, Remembering Paul Farmer. And one of the things that I found the most striking in your piece is a passage where you describe how alienated you felt during your public health training. You said that you weren't getting the kind of critical engagement on political and economic issues that you were seeking. And you said, and I'm very happy you didn't, but you said you wanted to give up on public health altogether. And it was at that time that you connected very deeply with Paul, at that sort of what sounds like a very crucial juncture in your life. It's clear that he provided guidance and inspiration, including from liberation medicine. I would love it if you might share with us a bit about the time in your life that was and how Paul's insights, including from this theology of liberation, helped move you forward.
Oh, yeah. So it might be hyperbole. What else was I going to do at age 23 or whatever? But Paul had this, as you mentioned in your introduction, he had this uncanny way of making everybody feel like they had a role to do, and you were so important. But one of the things he said was, no, like there's so many people around you who have these, who are thinking critically about these issues, and you need to really like open up and engage with those groups of people. He also then, of course, sent me some reading material. Like that was sort of like always Paul's way with me is, oh, and have you read this? Or maybe I should say that was the beginning of our relationship. I think near the end, I was looking through some old text messages, and he was actually asking me if he needed to read something, like, oh, should I read this? I have this in my library, but I didn't love it. So, should I bring it out? And I would say, no, that sucks. don't read it. But so I guess the way that I would say this is he always gave us this sense, I think each of us who engaged in particularly those of us who felt like we weren't able to contribute in the ways that we wanted to, he was able to say, I think often encourage us very deeply to kind of do that work. The liberation theology stuff, he actually sent me an email that I had to decode with friends, because I think he used the word hermeneutic and heuristic, and like, you know, my friend was like, you should not have to have an email where you need your dictionary to understand what he's saying. But what I did was I actually, you know, ordered the books and I started to read. And what I found so compelling was it offered him, and I think to some extent offered me at the time, a moral anchoring for the work. So he was saying, one of the problems that I have as an anthropologist, as a critical social scientist, a person who's a part of the resocializing disciplines, is we spend a lot of time with critique. We spend a lot of time doing that critical work, which, yes, is important, but we also need something that will anchor us morally and ethically, that gives us a path forward so that we're not caught in this sort of constant cycle of critique and reason, right? So we actually need a path forward for doing the kind of work that we think is important and necessary in the world. And liberation theology, I think, offered that, you know, pull scripture, pull these different elements of activist accompaniment work in poor communities. And he said, this is the thing, you know, I can do the critique. I have to do the critique. I have to do the reframing, but I also need a reason and a path to be able to do and change things. And so that was sort of like the thing that made me feel like, okay, yeah, maybe I can do this. Like maybe I can stick out the next year and a half hearing people say ridiculous things about poor people for that reason. And so, yeah, I'll just stop there. That's
thanks. Every time I saw him, he gave me a book. And so I imagine that he must have just like traveled around the world, always with a suitcase of books. I mean, I can't imagine how. Didn't he always give you a book, or at least send you stuff if you didn't have a physical book?
He gave me quite, actually, you know what, in our last few years, he was stealing books from me, which I think was so one of the things he does is he liked to mark up he liked to annotate his books very closely and carefully. And so he saw me leaving my mailbox with a book and he said, "Oh, what's that?" And I said, "Oh, it's a book that I'm in. I just got the first, you know, the copy." He said, "Oh, that means I can't buy it for myself yet. So can I take yours?"
So you have a net loss.
But then someone ordered me another copy. He says, "Well, once he's like, I'm not borrowing it." He actually told me, "I'm not borrowing it. I don't borrow books because I write in them and I need to have the book. So I'm just going to send you a new one." And so I was like, "Okay, Paul, whatever." I said, "I have a French version too. Can you take that one?" He's like, "No, I don't want it." But yes, I would often come back to when we were in the same office building, I had books on my desk with, you know, signed. And in fact, in my parents' house, when I was there, I found books that he had sent them and written, you know, signed. So yes, that was definitely.
Also, I very much recognize what you were saying about the sort of the moral and ethical underpinnings or kind of compass, because when he was here and you know, students were around him, there would be students from all different backgrounds, you know, there'd be economic students and engineers, and he would still sort of find a way to point to that kind of compass regardless of kind of what path you were on. It was really amazing. Chris, staying on this kind of you know, moral underpinning, ethical underpinning of Paul's work, you wrote a review for a medical journal, The Lancet, back in 2010 of a book that was called Partner to the Poor, a Paul Farmer Reader. And in your review, you praised Paul not just for his humanitarianism and his humanity, but for his work as a social scientist and for the way that he championed human rights. And you are in London today for a meeting of the International AIDS Society Lancet Commission on Health and Human Rights, which I believe you're co-chairing. How is Paul's work, kind of helping to shape the commission? How is what he did and underpinning to the work that you're doing, with this new and very timely commission?
Well, thanks, Gavin, and good to be with you all. Yeah, it's a really important question, and there are many different ways to go about it, but I would really point to two different strands of Paul's work that really came across in his writings and of course in the wonderful inspiration of his life and work, and certainly with partners as well as at Harvard. And the first of these is that, of course, he did have formal training in anthropology, had a PhD eventually in anthropology from Harvard. He used that discipline, which Adia just described so well as very much a critiquing tool. But in many ways, he turned it on its head. So much of anthropology is looking at other cultures, other societies. Paul really also turned that critical lens of anthropology on the power structures that shape global health and that shape healthcare. And that is why, of course, one of his really important books, Pathologies of Power, was very much about trying to understand the culture of power and the ways that it reinforces inequities, and that those inequities really profoundly drive health outcomes. And I think that was really powerful and enormously helpful. And then, of course, he was also a physician and an immensely practical man. I think you could think of him in some ways as a kind of practical visionary, because he really did try and make real what he cared about and thought was important. And Partners, of course, he co-founded what is really a medical services organization that focuses on the most marginalized, focuses on quality healthcare for the poor, and is a health delivery mechanism and system. And I think that the ability to do both of those things, to both have a kind of rigorous intellectual approach with a discipline like anthropology, to aim that at the world as it is and the power structures that exist, and think critically about it, and then be very much a part of the solution, trying to really implement health equity in an authentic way, is really extraordinary. There are very few people who both have that vision and have an ability to realize it. And I think that's part of what is so inspiring about Paul, and why his vision was able to encompass so many other people. And to inspire so many other people. And I recall many years ago when our student global health group invited him to speak at Hopkins, and there was this kind of intense buzz, and I was doing something and couldn't get into our biggest conference room until a little bit late. And I was sent to an overflow room, which never happens. and I said, "What's happening?" And I said, "Well, it's the fire restrictions. We can't fit more people in that room." And you realize that Paul had that ability, I think, because he truly was a practical visionary.
Thanks, Chris. I mean, clearly, Paul was very comfortable, connecting with presidents and prime ministers and heads of state. But what I also hear, I didn't see this because I didn't round with him, at Harvard, at the hospitals there, but that when you were with him there, he knew everybody, and he knew everybody by name. He knew the names of porters. He knew the names of the people, at the front of the desk. He knew the names of their kids. And he would, I hear, just loved just hanging out and chatting to folks. You know, he would bring them presents, he would bring them books. I mean, you know, there is a lot to this man that is really quite extraordinary. I wanted to, Chris, pick up on your point of sort of health delivery, not just talking about it, but doing it, which I think is a fantastic segue to you, Jonathan. I think I mentioned to you, I read a really wonderful interview with your colleague, Dr. Beyler, and in the interview, he says that in August 2014, he took a call from Paul, and on the phone call, this was the call when Paul said that PIH had now made a commitment to come to Sierra Leone. And apparently in the interview, after that call, he put down the phone and he literally danced around the house, like literally danced around the house. What is your sense of why Beyler was so thrilled? What was the excitement about? What was the hope, that, of some kind of transformation from PIH coming to Sierra Leone, and how did it play out, and what is your sense of the impact that it's had? I mean, you're obviously there during Ebola, during a very difficult time. The work is ongoing. Give us a sense of what that's like.
Well, first of all, thank you, and apologies on behalf of Beyler, who I know wishes he could join everyone. So I'm standing in for Beyler, and I'll try to capture Beyler's spirit as best I can when I respond to the question. But I just wanted to thank everyone at Duke, and I feel honored to be part of this panel. And hello, Adia. It's good to be with you again. Paul would be very thrilled about this panel, I can assure you. So, we were all dancing when PIH decided that we would be able to go into West Africa during the Ebola outbreak. And West Africa was a place that was really dear to Paul, and I think he was publicly talking about this in the last several years, but and I don't think he would mind if I shared it. Paul, before he went to Haiti, and obviously gained some notoriety around the work that he established there, Paul had applied for a Fulbright scholarship in West Africa. In fact, I believe he wanted to go to Sierra Leone, and he was rejected from that Fulbright. And of course, he doesn't have any regrets about that. But I think in the back of his mind, he knew that West Africa had among the poorest health systems in the world. And when the Ebola outbreak started in 2013, Paul was receiving phone calls from presidents and ministers of health across West Africa, sort of pleading with PIH as a global health organization to come and support. And Paul started an advocacy effort pretty early on during the Ebola outbreak to get PIH into West Africa. And this was a big deal for Partners in Health, because at the time, over 35 years, we'd only gone into 9 countries at the invitations of ministries of health. So to establish ourselves during the Ebola outbreak really meant that PIH would be there for the long term. And that would mean we would need to have all of the pieces in place that we've had in Haiti and Rwanda. Of course, Beyler, as a Sierra Leonean physician, was ecstatic because he had wanted PIH-style intervention to come to Sierra Leone since he started working as a physician and since he learned about Partners in Health. And what we were all thinking, and I started at PIH, as you mentioned, in 2009, what we were all hoping was that we could have this idea of conquering a failure of imagination. This is what Paul talked about frequently. This idea that we don't allow power structures that are based in places like Geneva or New York or Paris to dictate what's possible on behalf of poor people living in places like Sierra Leone. And Sierra Leone has a long history of exploitation, slave trade, colonialism, extractive industries, the decade-long civil war, leaving the health system decimated. And, there wasn't a medical school in Sierra Leone until 1988. And so when we think about the fact that there are 150 physicians in a country of 8 million people, in the US state of Massachusetts, which has a similar population, there are 25,000 physicians. And perhaps we can have a conversation about whether that's sufficient number of physicians or not, but certainly we can all agree that 150 physicians in Sierra Leone is wholly insufficient, considering that it has among the highest maternal mortality ratios in the world. And so we were all dancing because we wanted to see the transformation that happened in Rwanda and continues to happen in Rwanda and is happening in Haiti to be able to happen in other countries that have been written off for decades, if not centuries. And Sierra Leone, with all of the health indicators as low as they are, we really felt that Partners in Health, partnering with the Ministry of Health, could have this transformative impact, and we could do it more quickly, and we could learn lessons from some of the challenges and failures that we faced in places like Rwanda and Haiti. So when Paul advocated for this across PIH, there was almost unanimous excitement around going into West Africa, even though we knew it would be challenging. We went because of Ebola, but we stayed because of all the reasons I just mentioned. And over the course of the last 8 years, we've seen a dramatic impact, and it's certainly not enough. But Paul really pushed us to think more broadly about what's possible. And I think that's kind of what I take with me from, the 17 years that I worked and knew Paul, is this confidence that he gave everyone around him. He made everyone in the room feel listened to and heard. And that even if they disagreed with his approach or had a different understanding of international development, he never shamed anyone. He always met people where they were and tried to encourage people to think about how to use their power and their privilege to do more on behalf of poor people. And so that sense of dancing that Beyler felt is still being felt today, about the possibility and how we can sort of reimagine the world and reimagine global health in his honor, but carry that mission forward. There are so many stories to share about sort of the excitement we had about going into West Africa. But now that we're based there, we couldn't be more proud of the gains that we've had and the challenges that we're still trying to overcome. And so Paul was really instrumental in getting us to West Africa. And now we're carrying forward his vision as an organization of over 600 people, as one of the largest employers in the country. And we ought to be 6,000 people or more. And if we do our jobs right, we will.
Thanks, Jonathan. I want to pick that up, that theme of kind of serving the poor wherever they are in the world, and turn to Jade, because you volunteer for Partners in Health Engage, National Steering Committee coach, Duke chapter lead. I would love you to tell us about that experience and also share your reflections on how Paul's legacy has influenced your own work, co-directing and leading the Paul Hom Asian Clinic for the medically uninsured immigrant Asian community in Sacramento.
Thank you so much for your question, Dr. Yami. It's such an honor to be here on this panel. I think I'll start by answering your question by telling you a little bit about how I was introduced to the work of Dr. Farmer and how that inspired me to throughout my years at Duke and also beyond now that I'm in medical school. So I was introduced to Dr. Farmer's work in my freshman fall focus class with Catherine Admay of DGHI in Sanford. And one of the first articles that we read was called Rethinking Health and Human Rights, Time for a Paradigm Shift. And in this article, he talked about the idea of pragmatic solidarity. So the idea of reallocating resources and services to people who were directly affected by structural violence. And he talked about how physicians were natural attorneys for the poor and how using a health angle could promote a broader human rights agenda. And at the same time, we were also learning about the case study of how Partners in Health changed MDR-TB policies or multi-drug resistant tuberculosis policies in Lima, Peru, and proved that it was possible to treat multi-drug resistant tuberculosis in low resource settings. And from that instance, I was hooked. It was such a light bulb moment for me. And I was so inspired by Dr. Farmer's work in PIH that I too wanted to become a physician who was an attorney for the poor and who practiced pragmatic solidarity. And right after that course, which quite frankly changed the course of my life, I was looking for ways to practice pragmatic solidarity. And as a college student without a lot of technical or clinical skills, I felt a bit limited in my ability to do so. But then I found community organizing through Partners in Health Engage, which is the grassroots advocacy arm of Partners in Health. And community organizing is a great way for us to all be able to take part in a way of changing structures of power. And through PIH Engage, we were able to hold different educational events talking about the core principles of Partners in Health. So liberation theology, health as a human right, and things of that nature. We were able to fundraise for the Maternal Center for Excellence in Malawi and the University of Global Health Equity in Rwanda. And we made countless phone calls and lobbied different members of Congress to call for increased global health funding. And I was fortunate enough to be a part of this organization for all 4 years throughout Duke, and also 2 years between my time at Duke and medical school. And I was a part of that national steering committee, coaching other young leaders who were a part of the network and helping to build that national agenda. And after college, I was still looking for ways to practice pragmatic solidarity. And I had that in my mind when I took my first job out of college. I worked for Advanced Access and Delivery, which is a global health nonprofit based here in Durham, North Carolina. And I was able to do work in tuberculosis and COVID, able to collaborate with Socios and Salud in Peru, and to work with the Ministry of Health in the Republic of Georgia, as well as local public health authorities in Oklahoma City. And as a second-year medical student, I'm still looking for ways to practice that pragmatic solidarity. And one of the ways in which I do this is as co-director of Paul Hom Asian Clinic, which is a clinic for low-income and uninsured Asian immigrants in the Sacramento area. And I spend majority of my weekends working in primary care clinics, cancer screening clinics, and organizing cardiology and pulmonology clinics. And I'm just going to share a quick patient story here. I had a patient over the summer who was about 50 years old. He had just emigrated from China about 7 months prior. And he was low income, uninsured, and had limited English proficiency. And after speaking to him for a little bit and listening to his symptoms, I realized that he had stable angina, which is a pretty serious heart condition. And my attending physician and I decided it would be really important to send him for urgent care. And because he was uninsured, we immediately helped him sign up for healthcare insurance. And he was able to go to the emergency room, was referred to a cardiologist, and ended up having an emergency heart surgery because it turns out he had really severe heart disease. And I think about the Partners in Health accompaniment model, where patients' social and economic needs are also addressed in addition to their clinical needs. And even though we don't have a formal system of community healthcare workers at the clinic that I work at, I was really proud that we were able to kind of see this patient's treatment all the way through and address some of his social and economic needs. And I am very early in my career, but I do see how sometimes realizing that preferential option for the poor and delivering healthcare to the poor can seem like an insurmountable task. But it's in times like these where I really think, what would Dr. Farmer do for his patients? And I just hope that someday I can be half the physician, half the advocate, half the accompanier to my patients as Dr. Farmer was.
Thank you, Jade. That's a very powerful story and example, a lived example of accompaniment. I also just want to quickly thank Adme, firstly for suggesting that you join our panel. I'm really delighted you were able to. And also I have to just say, Adme is one of Duke's most beloved professors, and there's much that she has in common with Paul Farmer. Most notably, she may not know this, I once went to a show at Motorco and she was there. She knew absolutely every single human being, every musician. She knew like the roadies, she knew like everyone in the audience, every Duke student came up to chat with her. Anyway, I want to make sure that there's time to open this up to questions that you may have, but I'm going to just take this opportunity to ask just a couple of questions for anyone on the panel, maybe get brief responses. Beyler was actually interviewed for the obituary that Nature did of Paul Farmer, and he said that Paul is my teacher, my mentor, my colleague, my friend. I call him Pa because he is like a father. Barry said, I am devastated. And I was lucky to join Paul when he was here before the pandemic hit. And whenever Paul visited, he said to us, I want to meet students. I want to meet the global health students. I want to meet the medical students. He clearly really wanted to and really enjoyed doing so. And he had all the time in the world for them. And I would love your quick reflections on Paul as a teacher and as a mentor. I'm just going to open this up to everyone. Yeah, go ahead.
So, when Paul would come to Chicago, sometimes with very little notice, he would actually say, "What are you teaching? Can I come?" And it didn't matter what I was teaching. I would just say yes, because it's one less prep. But he would actually also ask to see the sort of Facebook, for the class, see the little. So he would actually have memorized every single student, the face and the name before coming. And then he would also do a thing where he would ask them a little bit about themselves, and so that when he had the opportunity, he would be able to call on them, and when they had questions or things like that. One of my students who I had as a first year and as a senior, actually before as we were introducing ourselves to each other in class, she said, "Before I finish, I have to say, Professor Benton brought Paul Farmer to class. I had no idea who he was." She said, "Do you know what this means? She brought this famous person. That means she's famous too." And she, and I was like, "I'm not famous, but I did bring a famous person." And I brought him because he wanted to be there. He wanted to engage with the students. He wanted to, it was also like a sort of sideways way of also getting to hang out with me, but it was a really wonderful and endearing thing that he was able to do, which was to actually learn everybody's name, to really fully engage with them and their engagement with sometimes his work, if I had enough foresight to actually have his work be a part of it. And so, yeah, I would say that was sort of the essence of who he was. He's ridiculously good at remembering the names, but also just wanted to be in that space of excitement and discussion in a way that I always thought was really, really quite fun and awesome.
Thanks, Adia. I usually say to myself, by the midterm break, I need to have memorized everyone's name, and I feel good if I've done that. Now I feel shamed. Jonathan, you saw him mentor folks, in many settings. What are your thoughts?
Yeah, I think, one quick anecdote that has nothing to do with mentoring students, but we were in Chicago together maybe 10 years ago, and he was giving a talk with Gustavo Gutierrez, the father of liberation theology, who Paul loved dearly and teaches at Notre Dame. And there were maybe 1,500 people at this talk. And at the end, Paul was signing books, and he stayed until around 2:00 in the morning, and every single person waited in line. And at the beginning of the line, after he gave the talk, there was a group of students from Creighton University. I remember the name of the university, but he met about 8 students, and he asked all of their names and signed their books. And then at the very end of the line, around 2:00 in the morning, there was one student from Creighton who had missed the bus to this event. And Paul said, "Are you friends with," and then listed all 8 students' names that he had met hours earlier. And he was just kind of remarkable in that way, in his recall and how deeply he listened. And there is nothing Paul took more seriously than his time with patients. And, in Sierra Leone or in Haiti, those are the 2 countries where I worked most closely with Paul. But he would spend entire days and only see 2 patients. And he would stay with those patients, and he would teach the clinicians from Sierra Leone and Haiti and have conversations with them and challenge them to think about the type of care they were providing or why they were making clinical decisions for this patient and what other interventions they might do had they had more resources or more diagnostics. And, I am not a clinician, so I would only observe this, but he loved being with those students. And he used to write we would be in the car driving back to Freetown, the capital of Sierra Leone, and Paul would be writing long clinical notes on his iPhone and send them to WhatsApp group of those clinicians, and years would go by and he would keep following up with those patients and make sure that they were still being supported either clinically or with social support. It was a remarkable thing to see Paul round both with students and patients. I feel very lucky that I was able to witness that, and it inspired me to go back and start a medical degree much later in my career. So he was very inspirational and a mentor to many of us.
Thank you. That's a remarkable story. Chris, I want to hear from you, but at the same time, I also want to ask, you and I both work in global health. We're physicians, but aren't seeing patients anymore. Paul was seeing patients literally up until the night, I believe he was rounding on the night before his death, which is very unusual for someone so senior in global health. Why do you think he maintained that, active clinical practice?
Well, I think it was very much a part of sort of who he was as a man, that he very much wanted to stay an active physician and provide care. And I think, it was the great American poet William Carlos Williams who talked about his practice as a practice. And what he meant by that was that his medical practice, he was a general practitioner in New Jersey, in Paterson, New Jersey, was also very much a kind of spiritual practice, a life way of living and giving meaning to life. And I think that was very fundamental to Paul, and very much a part of his path. I will say we've had over the years a number of fellows and trainees jointly, and had people that I'd worked with at Hopkins who went on to go with Paul, or then folks who'd worked with Paul coming to Hopkins. And so I got to see a lot of these, particularly the physicians, but other folks in training as well. And there's no question that a very big part of what they were coming away with was a way of being a physician, as a provider, as a caregiver, but also really as a profound kind of act of compassion and advocacy as well. And I think that stayed a part of his practice and praxis all his life. I will reflect that the two most recent of those folks, Jean Richardson is one who was doing a postdoc fellowship with me some years ago, and just appeared in my office one afternoon and said, I'm not going to finish this fellowship. I feel compelled to go and work in the Ebola outbreak in West Africa. And I said, well, if you feel compelled and you think that this is the right thing, I'm sure it is. And, but make sure you really get training, because it's no small thing trying to provide care in those very challenging settings. And he said, oh, I've already done that. God, I'm just back from Atlanta. Sorry, I didn't get to tell you. I did the CDC training already, and I'm going with Partners in Health, and my plane leaves in about 18 hours. And I think he's still actually working with Partners, and wrote a really interesting book on decolonizing global health as well. The other, Nick Cuneo, was an advisee of mine when he was a medical student at Hopkins, and then went on to do his residency and got very involved. Actually, became fluent in Haitian patois. He taught Haitian language, Haitian Creole. And then came back to Hopkins after working with Paul to start an asylum clinic. It's the first time Hopkins has ever had an asylum clinic for people seeking asylum and doing forensic examinations. And that has really turned into a whole new program that we really needed and that we didn't have. So, I think this session we're talking about the life and legacy of Paul. It seems to me that those kinds of people are really his legacy, and the way that they were inspired, the work that they're doing, and of course a part of that legacy is the training he provided to physicians, many other people too, but certainly physicians as well.
Thanks so much, Chris. Jade.
Yeah, I just wanted to echo some of the previous sentiments. I'm just kind of starting off in my clinical work, and I can see that clinical work can be very gritty and difficult to do at times. But I think what makes it so worth it is being able to connect with patients and hear their stories. And I've been lucky enough to have been mentored by some of Dr. Farmer's trainees and his friends. And I've heard plenty of stories of how Dr. Farmer loved going on rounds, really deeply cared and loved every one of his patients. And I think that clinical work really gives you kind of a sense of urgency, as well as a sense that you can't abandon people during their times of crisis. And I think during, through Dr. Farmer's writings, you can see how individual stories that he heard from patients and the patients that he connected with really shaped the larger structural changes that he was advocating for.
Thanks so much, Sherry. We've got about 10 minutes. I'm going to open this up to the audience now for questions. Are we passing a mic around? Can we? Is that possible? Shall I just be the mic passer? Here we go. Okay. Here, please take the mic.
Hi. I just have a practical question. How do you guys prioritize the work in these communities? Because healthcare, it's a very huge word. And I wonder, how do you guys go into these places and how do you prioritize the work? Thank you.
Great question. Who would like to take that one? So many needs. How do you prioritize in global health?
Well, I could just share from a Partners in Health perspective. We look at the burden of disease. That's sort of the first thing, but we really push ourselves to think outside of sort of vertical programs. I think in global health, frequently you have these sort of short-term projects that are focused on something like multi-drug resistant tuberculosis or HIV. And so you'll see lots of sort of funded projects that are HIV focused or MDR-TB focused when you have people coming to clinics and hospitals not because they're infected with HIV or MDR-TB, but because they're sick and there's not primary care around. So PIH's model, just very, very briefly, includes strengthening clinics and referral hospitals so that throughout the continuum of care, people have access to the same type of healthcare we would have in the United States. And that requires, in our opinion, in our model, community health workers that are trained and paid, linking patients to clinics that actually have all of the things that they need. And Paul used to talk about the 5 S's: staff, stuff, space, systems, and social support. So really investing across all of those areas. And by doing that, you not only address the primary healthcare needs of the population, but you also have programs for HIV, MDR, TB, et cetera. And so there are limited resources in global health, and that's true. But there should be far more resources based on the type of world that we live in. And so advocating for more and making sure that, and I said this earlier, making sure that we, those of us in positions of power and privilege, use that to advocate for more and to think more broadly about what's possible so that we can prioritize more rather than less.
Any other questions? Yes. Oh, good. Because we've only got one mic here, so that would have been 0.
Hi, my name is Beyrer, and I'm a parent to a senior at Duke that's going into medical school. So I had a question for Jade. I was just curious as to how were you able to be involved in so many things? You're very inspiring, and I just kind of was wondering, did you have a gap year between college and medical school that allowed you to pursue a little bit more of those goals that you had? Just if you could comment a little bit on that, I'd be loving to hear that.
Thank
And
you so
thank you.
Thank you so much for your question. Yes, I did take 2 years in between my time at Duke and beginning medical school. So I mentioned I worked with a global health nonprofit called Advanced Access and Delivery, which is based here in Durham. And during that time, I was able to work on different tuberculosis projects as well as COVID projects during the pandemic. And I think my biggest advice for college juniors who are like interested in going down this path would be to, I guess, like keep a really open mind and also read broadly, listen broadly, and be willing to get all these different experiences outside of med school, because once medical school starts, it really doesn't stop.
Thank you.
Thank you.
Question at the front.
Thanks for running all the way for the mic. Yeah, just for anyone on the panel, I was wondering, a lot of these issues seem to be very multidisciplinary or multifaceted problems, like to be able to care for the poor, like a global standpoint. Like there also has to be economic justice and, like liberation theology and like the preferential option for the poor, like so many different areas are intertwined. And I have more of a corporate background within the tech industry. So I was wondering, in what ways do people with my background, like how can we partner with the global health community to solve some of these problems?
Who wants to take that one?
You know what?
Well,
I bet John actually also has, but Chris, you probably have a better answer.
I can give a short answer, which is that we're seeing really a number of technological advances that have real application in trying to do better with global health. And I think one of the things that we saw very clearly with the COVID pandemic was the real coming of age of telemedicine and virtual provision of healthcare. And there's a number of technologies like, the smartphone that are really leapfrog technologies. So, just one simple example, there are many, many countries where it still takes forever to get a landline and they're kind of useless to have. But where, smartphone coverage is high, and there are just an array of health innovations that can be delivered via smartphone. So there's a great deal of tech innovation in this area. WHO now has a digital health innovation center. It's run by a former colleague, friend of mine, Alain Lebrique, and I think there's a great deal that can really come in this way. We also, with DGHI, have a number of collaborations with the School of Engineering because there's again just an array of innovations from water and sanitation systems to new ways to use light to do low tech imaging. It's an exciting area, and there are a great deal of applications that could really make a difference in places where people have limited access now to healthcare.
Can I was hoping I could also jump in based upon
Go ahead.
So actually, when early in the COVID outbreak in Chicago, I actually hooked up with Partners in Health because we were trying to, I have an ID doc friend based at the University of Chicago who was trying to do, basically what was happening was Cook County and the city of Chicago's databases did not talk to each other. It sounds very simple, but she was trying to do a contact tracing thing amongst her patients and wanted to be able to interface with those. And just having people from Partners in Health who were actually just database contact tracing folks helped us to kind of come up with a solution to reach a lot of the patients who are not being reached by all of these other systems. So it's just like really simple things I keep thinking about there are these really like one of the reasons anthropology and anthropology of STS, which is what I do, is important, is because I was able to say, I see a disconnect here. Our infrastructures don't match. And we need to have somebody who can sort of patch that in and help us think about these questions socially too, right? So how do we think about the barriers to care for all of these folks, but also the systems that are supposed to track and trace and improve care? So that was actually like one very, very basic like interface. Another one was, and not to steal your thunder, is I actually employed research assistants from engineering who are computational epidemiologists in training. And so I was able to help say, well, why does this model look like this when we're trying to build access into this particular financing mechanism? Why does why wouldn't the model include this and why wouldn't it include that? And so I would have these students go back to their professors and say, yeah, we don't understand that, let's work through this model. Let's talk through this computational model that would allow us to really like better distribute access. It's even that kind of stuff, that's sort of nitty gritty back end stuff that ends up being really significant when we're trying to really improve access. You can't do just the ethnography, or the ethnography has to also engage the technical actors who are being observed, right? Like to be able to change things. And in fact, I think that was Paul's legacy, right? He critically reread the social science, the epidemiology, the clinical literature in ways like very early on, before anyone was really doing this in the early 90s, like really saying, let's go through all of the literature and see where they messed this up so we can fix it. In this way that I'm always pointing to, I'm like, why doesn't anyone read his old shit? Like, no, pardon my French. That's where it started. That's where we all started to kind of like dig in and see the point of our critique, but also the ways that we can sort of hack all of these other systems that will help us to get through to the end point, which is the other side of that arc, right? Bending that arc towards social justice. So,
Oh, we could not end on a better bending the arc for social justice. We are out of time. Thank you so much, first of all, to the panelists, Jade, Chris, Jonathan, Adia. Let's give everybody a round of applause. And just a reminder, Bending the Arc is going to be shown tonight at Griffin Film Theatre at 7 p.m. Thank you so much for coming along. Ben, anything else from you? That's it. It's a wrap. Thank you so much, everybody. It sounds like Adia may have a job for you, by the way. Didn't you hear that? That sounded like a job offer. Chris, Adia, Jonathan, thanks so much. Really appreciate it.
Yep.
Thanks, Gavin.
Adia.
Good to
Thanks,
see you.
Jade.